Dear friends, let's begin with the prelude session for today. And we are going to have three important topics. The first will be by Dr. Raj Kedar, and he'll be taking MRI and characterizing renal masses. The second will be by Dr. Ravi Thapar. So we'll be talking about MRI difficography, and then there'll be a lecture on fetal MRI. So let's begin with the first topic for the day by Dr. Raj Kedar. Sir is Professor of Radiology at University of South Florida and Radiologist in Chief at Tampa General Hospital. He is Director of Body Imaging and Fellowships as well as MSK Faculty, Vice President of Florida Radiological Society. And he has several awards to his credit, including the Teacher of the Year Award and also Teaching Award, Chair Awards, and Golden Apple Awards. So thank you, sir, for your kind consideration and your time. Let's begin with the talk.
Good evening. It's my pleasure and honor to be part of this course. And I would like to thank Dr. Patkar and Dr. Verma for inviting me to talk about characterization of renal masses with MRI. Unfortunately, incidence of renal cancer has increased by 30 to 40% over the last 30 years or so. And this is predominantly due to incidental lesions due to increased imaging with ultrasound and CT scan. Although most of these lesions are less than 4 centimeter, increase in diagnosis has not resulted in better clinical outcome. In fact, the reported increased mortality from 1.5 to 6.5 deaths per 100,000. And this is predominantly due to overdiagnosis and surgeries and aggressive management, even slow growing tumors, which may or may not show growth over the time. The cost-effective strategies are necessary, especially to identify the clinically significant renal masses that could evolve into life-threatening disease versus the overtreatment of benign or indolent malignant lesions that can be observed. As we know, ultrasound is very cost-effective. It is very diagnostic for simple cyst. However, it has its limitations with smaller lesions. Patient's body habitus characterized in complex cystic masses, differentiating from complex cystic masses to solid lesions, and cannot stage the disease. CT scan is very sensitive and specific for renal masses for greater than 2 centimeter in diameter. However, it does have its own limitations in complex cyst containing hemorrhage of protein, lesion size, intraparenchymal lesions that cannot be measured accurately as far as Hounsfield density is concerned because of volume averaging and misregistration artifacts. It can be limited with renal function. So that's where MR comes in. MR has got excellent soft tissue contrast, due to which we can use multiple sequences and parameters to characterize the renal lesions. We do not need iodinated contrast, so some of the patients who have allergies can be still scanned with this. In cases of renal insufficiency, now with newer microcyclic agents, we can give IV contrast even in end-stage renal failures. My learning objectives for this talk are to discuss typical and variable features of common renal tumors, how MRI can help as a problem-solving tool to characterize the renal lesion by which the clinical management, planning intervention, and avoiding unnecessary procedures. The plan for today would be to talk about different types of tumors, how we can characterize those with MRI. I'm not going to discuss potpourri of all renal masses. I'm not going to talk about inflammatory or pseudorenal masses or cystic lesions. We are going to briefly talk about renal cell carcinomas and its subtypes, some typical and atypical AMLs, oncocytomas, and other tumors. First of all, technique. Technique is very important. Our MR protocol is same for all abdomens. It has coronal T2, axial T2 fat sat, gradient echo, in and out of phase imaging, DWI, and coronal and axial Dixon. Post contrast, we typically do all these sequences in with post contrast images in arterial, venous, 3-minute delay, 5-minute delay in coronal, and for all, we do subtractions as well. The money sequences that can really make difference in diagnosing renal as well as liver lesions is subtraction, in and out of phase, and fat sat. Remember that for renal tumors, fat is your friend, and diffusion weighted images. As far as subtraction technique is concerned, it is grossly underutilized. It drives me crazy when I see outside scans where subtractions is not done. This is very simple. You just have to push a button and machine does it for you. There is no extra table time or patient time. I think it's crime not to do subtraction sequences when it is so easily available, and it makes a lot of difference in characterizing these lesions. So essentially in this, you are subtracting pre-contrast images from post-contrast images. So it will subtract out the hemorrhage, hyperintensity within the lesion, and it will just give you pure enhancement within the lesion, which helps you a lot. So for example, in this patient, this is a lesion with slightly hyperdensity. There's peripheral calcification following intravenous IV contrast. There is no way of measuring how much this lesion is enhancing. Same thing with MRI. You can see on T2 weighted images, it is hypointense. So this is a cystic lesion. On pre-contrast even, it is markedly hyperintense, indicating hemorrhage or proteinaceous material with IV contrast. You cannot exactly determine whether this is contrast or the hemorrhage within the lesion. But when you do subtraction, you can see this ugly nodule within this cyst, which was a papillary renal cell carcinoma, which would have been difficult to diagnose either on the CT images or non-contrast or non-subtracted images. So subtraction technique is very important. Another lesion, here on CT scan, without contrast, arterial phase, portal venous phase, or nephrographic or the corticomedullary and nephrographic phase, we don't know whether this lesion is enhancing or not. But on MRI, you can see that on T2 weighted images, there is some heterogeneity within the lesion. On pre-contrast images, there is area of hemorrhage. But with IV contrast, we don't know how much of it is enhancing. On subtraction, you can clearly see that it has got low-level enhancement. This was another papillary renal cell carcinoma. This was a 50-year-old patient, shows an ugly-looking bilobulated lesion with hyperintensity on T1 pre-contrast weighted images. Even on T2 weighted images, the lesion looks extremely ugly, but with IV contrast, you don't know whether this lesion is enhancing or not, but on subtraction images, you can clearly see that this is just a hemorrhagic lesion. There is no abnormal enhancement within it. We followed this lesion for 3 years, and you can see that there is hardly change in this lesion. There's still some hemorrhage. It is still looking ugly, but there is no enhancement on subtraction images, which saved nephrectomy for this patient. This was a high-grade papillary renal cell carcinoma. You can see that this lesion has got extensive hemorrhage within the lesion. This area, we don't know what is happening with IV contrast without subtraction. We don't know whether this area is enhancing or not. And on subtraction images, you can see really ugly-looking papillary renal cell carcinoma, which can be easily diagnosed once we subtract that hemorrhage. So subtraction, very important for diagnosing tumors. How about in and out of phase imaging? This is especially diagnostic for angiomyolipomas and some of the clear cell renal cell carcinomas. Let's see how we can diagnose those. Angiomyolipomas come in different flavors. They can be very fatty, like this, where you are going to get this India ink artifact at the fat water interface, and this is diagnostic of angiomyolipoma. You can also see that there is fat here, which is going to suppress on fat site images. Another lesion, intraparenchymal angiomyolipoma, is going to show that India ink artifact all around it, as well as chemical shift artifact. Some of the lesions could be tiny, which will completely show dropout on out of phase imaging. If there are lesions containing less fat, then that portion of the lesion is going to show a drop on out of phase imaging. However, the problem comes when there is a lipid poor AML or clear cell carcinomas on in and out of phase imaging. However, it has been shown that the lipid poor angiomyolipomas tend to follow signal of psoas muscle on in phase, and they will show areas of drop in signal on out of phase depending on how much fat content is within the lesion. Whereas in renal cell carcinoma, they usually follow the parenchymal intensity on in phase, and on out of phase, due to intracytoplasmic fat, that is microscopic fat, is going to show uniform drop in signal, which is very characteristic of clear cell renal cell carcinoma. This is a clear cell renal cell carcinoma in phase, out of phase. Although this tumor looks slightly heterogeneous, you can see that on out of phase imaging, there is uniform drop in signal, and that's because of intracytoplasmic fat seen in this lesion, which is very typical. In lipid poor angiomyolipoma, again, we can see that it follows the signal of psoas on in phase. On out of phase, there are areas of drop in signal within it due to this small fatty tissue within the lesion, but it really depends on how much fat is within the lesion. This is lipid-rich angiomyolipoma, which follows the signal of surrounding fat. You can see it is getting saturated on fat site sequences, and out of phase imaging, it shows areas of drop in signal, typical for lipid-rich angiomyolipoma. How about diffusion and ADC sequences? This is especially helpful in differentiating cystic benign lesions from cystic renal cell cancers, can differentiate benign from malignant renal tumors, may be helpful in differentiating histologic subtype or grading the severity of the tumor. DWI is also useful in patients if you cannot give gadolinium, and that might be your only chance to grade the tumor. So here is a low-grade, this is a oncocytoma, which shows hardly any restriction, whereas this is a clear cell renal cell carcinoma. You can see how much restriction is there and low ADC. So very helpful. This is a busy chart, but let's tease it out. The RCC subtypes are clear cell, which is by far the most common, papillary, and chromophobe. It's important to differentiate between these three, as clear cell carcinoma tend to be very aggressive depending on its grade and stage and sarcomatoid changes. And one needs to be very aggressive in treating these tumors with nephrectomy, whereas papillary and chromophobe tend to be relatively slow growing, especially chromophobe. It has got 5-year survival of 80 to 93%. The management could be different here. In papillary and chromophobe, you could be You can do nephron sparing surgery, which will help in preserving renal function depending on patient's age. So very important to make sure the type of tumor which you may be able to do with MR. There are 4 things that you can look to characterize this renal cell carcinoma, different types of renal cell carcinomas. One is T2 signal, in and out of phase, type of enhancement, and whether there is necrosis or cystic changes within the lesion or not. So depending on this, we can see that in clear cell type renal cell carcinoma, on T2 weighted images, the lesion tend to be very high or intermediate in signal intensity compared with low intensity on papillary renal cell carcinoma and intermediate signal intensity on chromophobe type. On in and out of phase imaging, since clear cell renal cell carcinoma has got that intracytoplasmic fat, it's going to show drop in signal, usually uniform on out of phase imaging, which we saw earlier. Whereas in papillary renal cell carcinoma, there is drop in signal on in phase, not out of phase, but in phase. That's due to hemosiderin or hemorrhage within the lesion. Whereas chromophobe type is usually homogeneous. As far as enhancement is concerned, clear cell type shows avid enhancement, which is similar to the cortex of the lesion, whereas papillary shows minimal enhancement and chromophobe shows mild to moderate enhancement. Clear cell carcinomas tend to have necrosis within it. Papillary type may show some small cystic changes, and chromophobe tends to be uniformly solid without any necrosis or cystic changes. So on arterial phase, you can see here that this is the clear cell type renal cell carcinoma, which is showing avid enhancement similar to the cortex. There are areas of necrosis within it. This is partially exophytic, more than 3 centimeters at the diagnosis, whereas papillary is relatively hypovascular. You need subtraction images to see the mild enhancement. It is fairly well defined. And chromophobe, it shows mild to moderate enhancement, well-defined, no necrosis within the lesion. So how does CT and MR perform in characterizing intermediate renal lesions? Margulis and his group performed a retrospective study of 143 patients with indeterminate renal lesions detected on ultrasound. 77 had CT, 66 had MRI, and MRI showed definitive diagnosis in 95% of patients versus 78% on CT scan. MRI recommended only additional studies or recommendations such as follow-up only in 1% of patients, whereas CT recommended more than 10% additional evaluation. So MRI was more likely to give definitive diagnosis and less likely to recommend further imaging than CT. So let's go through a couple of scenarios to run through different types of tumors and where MR is going to be helpful in diagnosing these lesions. So scenario 1, MR can be helpful to further characterize lesion where initial CT protocol was not adequate. So this patient had CT scan without contrast, and you can see that this patient has got multiple renal lesions, except one. Probably rest of the lesions are not characterized on this non-contrast CT scan. You can go ahead and do CT protocol with arterial venous phase. However, still there are going to be some lesions which are not going to be characterized. As you can see on this MRI, that all these lesions look cystic. Some of this lesion, for example, this one is hemorrhagic lesion. There's small hemorrhagic lesion here, which would have been a problem with CT scan with and without contrast. But on MRI, we can show that all these lesions are benign, and this patient does not need a follow-up or any other study. MRI in this patient had CTA examination, which showed an indeterminate lesion here. We went ahead and did MRI in this patient, and we can see there's this lesion which was not characterized on with contrast is in fact an angiomyolipoma. We detected another angiomyolipoma here. These two lesions showed gross fat within it. So there was no additional examination necessary in this patient. Summarizing scenario one, MR can be helpful to further characterize lesions which are where the initial CT scan protocol was not adequate. So let's see whether MRI can be helpful in indeterminate lesion despite of adequate CT protocol. So here the protocol is adequate, but still the lesions could be non-diagnostic because in homogeneous lesion, if there is intermediate change in density, that is increase in density less than 20 Hounsfield unit, but more than 10 Hounsfield unit, then those lesions are going to be indeterminate. Whereas if it is a heterogeneous lesion, then it's going to be difficult to exclude smaller nodular areas within the lesion. So this is a renal mass or renal lesion here. You cannot see it on pre-contrast, but there was 90 Hounsfield unit increase in density from pre-contrast to post-contrast, which is non-diagnostic. So this is indeterminate lesion. We also have to remember that smaller cysts, which are intraparenchymal in central in location, can give false reading because of partial volumic artifact for those smaller lesions within the renal parenchyma. In this patient, we went ahead and did MRI, and we can see that on T2-weighted images, it's a cystic lesion. There's some internal density on pre-contrast T1, but however on post-contrast images as well as on subtraction, there is no enhancement. So this is a lesion containing mild hemorrhage. So advantage of MRI in such patients is we don't have to worry about pseudo enhancement. We have subtraction images to subtract out the protein or hemorrhage within the lesion. And we got very sensitive fluid sequences, which can help us diagnosing these cystic indeterminate lesions. There was this study done for potential renal donors, which is very important because we don't want to transplant any kidneys with renal lesions. There were 105 lesions, which were with average size of 1.5 centimeter. 94 patients, all these patients had CT scan with subsequent MRI. On CT scan, 94 of these 105 lesions were TSTC, that is too small to characterize by a CT. When they did MRI, in 99% of the lesions, MRI was diagnostic and no further imaging was necessary, out of which 83 were simple cysts, 8 were proteinaceous or hemorrhagic cysts, 2 were AML. So take-home point is MR can characterize small lesions that are indeterminate with CT due to pseudo-enhancement or partial volumic artifact. This was an indeterminate lesion, as this lesion was kind of bilobed or trilobed, and we can see following administration of IV contrast, you can see some septations within it. Is there some nodularity within it? So this was at least 2F lesion by Bosniak classification. On MRI, we can see this portion of the cyst has got dense hemorrhage. The other portion of the cyst did not have any hemorrhage, and there's an enhancing nodule, which was diagnostic of early cystic renal cell carcinoma in this patient. So MR is sensitive for detection of enhancing nodules in cystic renal lesions. It upgraded 73% of patients on this study. It had 95% positive predictive value for malignancy with enhancing mural nodules. How about lesions with low enhancement that is difficult to detect on CT scan? The solid mass, which is most likely to result in this conundrum, is papillary renal cell carcinoma. As we can see it here, this is the enhancement pattern of clear cell renal cell carcinoma, chromophobe type, and papillary type. And papillary type, you can see it shows very low enhancement with IV contrast compared with other two tumors. So if you suspect that there is very low enhancement, or rule of thumb is if you have difficulty in deciding whether it is enhancing or not, they consider it to be a papillary renal cell carcinoma, because in up to 30% of patients with CT, this enhancement is undetectable. These lesions tend to be hyper dense on pre-contrast CT, so it's difficult to measure the enhancement in many of these patients. This is a patient with looks like hemorrhagic cyst with IV contrast, and on pre-contrast images, the density was around 28 Hounsfield units. Following IV contrast on corticomedullary and nephrographic phase, there was enhancement of 16 to 17 Hounsfield units. So this was, although the lesion size is pretty large, it was still indeterminate. Whereas on MRI, you can see that this lesion has intensity similar to parenchyma with IV contrast. You can clearly see that there's some enhancement, which on subtraction images, we can clearly see that this is a solid enhancing lesion, which was papillary renal cell carcinoma. So over half of the papillary renal cell carcinoma did not show definitive enhancement on corticomedullary phase with CT. On nephrographic phase, it did show some enhancement. So nephrographic phase is probably the best phase, but MR did not have any problems detecting these lesions at all. So take-home point is, when reading CT scan for hyperdense lesion, nephrographic phase is key, although you are still going to call some indeterminate lesions with this. MR has better sensitivity and specificity for detecting enhancement of low level enhancing lesions versus hemorrhagic cyst in these patients. Scenario number 3, how about CT protocol is adequate? Lesion is enhancing, but the diagnosis is uncertain. So in this, the lesion is not fully evaluated with CT scan. For example, this patient, which was a fat poor AML, but based on multiple sequences and enhancement pattern and diffusion weighted images, as well as in and out of phase images, MR can characterize many of these lesions. For example, this is a clear cell carcinoma. This is probably typical. It shows hyperintensity on T2 weighted images. It is usually hypointense on T1 weighted images. It shows enhancement similar to renal cortex with areas of necrosis within it. There shouldn't be any problem in diagnosing this on CT or MR. We can see that on nephrographic as well as corticomedullary phase, nephrographic as well as corticomedullary phase, it's going to show marked enhancement, especially in corticomedullary phase. It is going to show a drop in signal, as I showed you before, on out of phase imaging, which is going to be uniform due to intracytoplasmic fat, which is also pretty helpful. Whereas in papillary renal cell carcinomas, which is second most common, they tend to be very cellular. They are hypointense on T2 weighted images. These are relatively indolent lesions, so it's important to separate these out from renal cell carcinomas. These tend to be bilateral and are more common in renal failure patients. Here, in this patient, there are multiple lesions. You can see one lesion on right side, which shows typical appearance of papillary renal cell carcinoma, which is low enhancement. and it is low signal intensity on T2-weighted images, whereas this lesion, we could see another lesion in the other kidney, which had similar features, whereas third lesion, which was there, was a simple renal cyst. So with help of MRI, we can easily diagnose papillary renal cell carcinoma, which may be indeterminate on CT scan. And you don't have to have aggressive treatment in these patients, depending on patient's renal function, age, and everything. You can do some other type of treatment. So papillary renal cell carcinoma commonly involves end-stage kidneys, often contain hemorrhage or cystic degeneration, usually homogeneously hypoenhancing. They can show some restriction on diffusion-weighted images due to their cellularity, which doesn't help. But unlike clear cell RCC, papillary renal cell carcinoma is frequently hypointense on T2-weighted images, whereas the clear cell type, there are hyperintense on T2-weighted images. This is one of the ugly-looking papillary renal cell carcinoma. We can see that it is hypointense on T2-weighted images compared with clear cell, which are going to be hyperintense. On T1-weighted pre-contrast images, we can see some hemorrhage. We don't know what is happening here, but on subtraction images with IV contrast, you can see multiple lobulations, fronds along the surface of this lesion, indicating aggressive type papillary renal cell carcinoma. How about chromophobe? This is probably the least common and more indolent type of low-grade tumor. It shares morphologic features and histologic features of oncocytoma. They tend to be iso to hypointense on T1-weighted images. They show mild enhancement with IV contrast, no necrosis. Their enhancement pattern is less than clear cell carcinoma. So they are something in between. So rule of thumb in these lesions is there are usually slightly hypoenhancing compared with the cortex. There can be diagnostic challenge in diagnosing oncocytomas. However, with MRI, there are certain features which can be diagnostic. These tumors tend to have central scar. They tend to be slightly hyperintense, which is kind of unique for oncocytoma. They are slightly hyperintense on T2-weighted images, and they show kind of slightly spoke wheel type of enhancement with IV contrast in corticomedullary phase. And on the nephrographic phase, they tend to be slightly hypointense. The another unique feature of these tumors is the scar doesn't enhance initially, but on delayed imaging, the scar will show enhancement, which will help you differentiate between the renal cell carcinoma and oncocytoma. The central scar, hyperintensity on T2 of central scar, delayed and complete enhancement. No intravoxel fat that is on out of phase is not going to show low intensity, was 97% specific and 55% sensitive in patients with oncocytoma versus renal cell carcinoma based on these two studies. So very powerful feature to differentiate this from clear cell type renal cell carcinoma. Another feature that has been described is segmental enhancement inversion in oncocytomas. So on corticomedullary phase, some portion of the tumor may enhance, which gets washed out, and then the other portion of the tumor will enhance on nephrographic phase, which is kind of unique for oncocytomas. We often have diagnostic challenge with fat-poor angiomyolipomas. Fortunately, these tumors tend to be, the percentage of these tumors is less. Whenever there is less than 25% of fat per high power field on path, they call it fat-poor angiomyolipomas. The key MR features in these patients is they are dark on T2. Unlike renal cell carcinomas, which are going to be high on T2, they do show restricted diffusion, which is a problem, but they do not show any necrosis. And they might show some areas of drop in signal or out of phase, depending on how much fat is within the lesion. Sometimes you may not be able to distinguish this from malignancy, and there is no shame in doing biopsy in these patients. Actually, this study was just published last month, which showed that if you see actually lipid poor angiomyolipomas on T2A images show this uniform low signal, and they show moderate enhancement on corticomedullary phase. And this is actually 80, this is diagnostic. Actually, this was kind of very useful feature in diagnosing lipid poor angiomyolipomas. This was seen in 83% of patients with the sensitivity was 83% and specificity was 90% in this patient. So maybe this feature is going to be very useful in diagnosing lipid poor angiomyolipomas. Sometimes on CT scan, although with naked eye, you might say that there is fat within this lesion, but when you actually measure those because of increased density from vessels, you might not get typical fat measurements. In those patients, MR is also useful because here you can see that this lesion is clearly has similar intensity as surrounding fat. It has got India ink artifact at fat fluid interface, and shows some enhancement with IV contrast. So MRI confirms AML. Sometimes you might be able to see this pushing of fat into the renal parenchyma, which is typical for angiomyolipoma from where it arises. So pretty diagnostic if you see it. So how about MR versus CT characterizing renal masses? This group did a study of 120 patients in lesions which were indeterminate on CT followed by MRI. The final diagnosis was based on pathology or follow-up. 39% of these lesions were benign masses such as angiomyolipoma, oncocytoma, or hemorrhagic cyst. The sensitivity of CT for diagnosis of renal cell carcinomas was 91% versus MR, it was 94%. Specificity for CT was only 28%. Remember, these are indeterminate lesions, whereas with MR, it was 68%. So using MRI in approximately 12.5% of patients, with malignant diagnosis on CT could have avoided surgery, whereas 2.5% of benign diagnosis on CT would have been appropriately recommended surgery, which was not done with CT scan. So another study which was published in Abdominal Imaging, which had 63 patients with indeterminate lesions, which were smaller than 2 centimeters. And of these 63 patients, MR was sensitive 100% of the time. That means it diagnosed all those 63 patients. MR was 95% specific, indicating benign versus malignant lesions. Of these 63, only 3 remained indeterminate following MRI. So MR take-home message is MR is great, has greater specificity than CT in distinguishing benign versus malignant diagnosis, and fewer lesions remain indeterminate after MRI. So wrapping up, MRI is indicated in evaluation of indeterminate renal masses on CT and ultrasound and provide additional diagnostic information which can be helpful in diagnosing and managing these patients. MR imaging is particularly helpful in distinguishing solid from cystic lesions when enhancement of renal masses is questionable, especially for those where net enhancement on CT is between 10 and 20 Hounsfield units. So we can either upgrade or downgrade Bosniak 2F lesions so that these patients do not have to go for follow-up examination every 6 months to 1 year for 2.5 to 3 years. Diffusion-weighted imaging and dynamic contrast enhanced imaging can provide specific information regarding tumor histology and staging. MR is especially useful for too small to characterize lesions. There are not going to be any lesions which are too small to characterize on MRI, lesions with low level of enhancement, hemorrhagic lesions, and complex cyst. And that's all from me. Thank you.
Thank you once again, sir, for taking this important topic in such a